today's webinar organized by IAPWC Team Karnataka. It gives me immense pleasure to see the kind of participation we have been getting from all over India. It proves that actually nothing in the world can stop the knowledge to flow from one side to the other person. You know, not even a virus. A virus can't stop us from sharing our knowledge. So, not wasting your any much time, I would like to welcome our chief guest, Pectoralis sir, who is Karnataka State President of IOP and has been a guiding pillar for our IAPWC team. His work and words have always motivated us. I welcome you, sir.
Thank you, ma'am.
And I would like you to say a few words about this webinar and about IAPWC.
No, I first of all congratulate all the effort made by Sumita ma'am, its team in the Karnataka IAPWC, and I see a lot of work, teamwork. I could see you, Shanti ma'am, all of you, and great speakers coming in. I wish
Thank you so much, sir.
I wish you get more webinars, more programs for Karnataka and all over India. And the way the hard work you have done, I see all on the promotions, the physiotherapy people in Karnataka now they come to what is women's salary is about. And I wish you the best, ma'am, and wish you the speaker also the best today. And wish more of webinars and seminars to come.
Thank you so much, sir.
Thank you, ma'am. Thank you, ma'am.
I would like all the participants to mute themselves. That's very important. Apart from that, everybody should mute themselves. Now, I feel very proud to introduce you to this our speaker for today. Today's webinar is on therapy aspect of pre and post botulinum toxin injection in spasticity dystonia. I invite Dr. Naveen Matthew Joseph,
Good afternoon, everyone. Okay, first of all, let me thank Manipal Hospital as well as IAPWC Karnataka branch for giving us this department this opportunity to present this topic. And let us go directly to the slides. So we selected this topic on botulinum toxin because we realized that physical therapists are the first contact medical professional for treating spasticity. And many a times, most of the type of spasticity can be managed by physical therapist alone. But only there are a few percentage of cases where you might need a physician or a surgeon intervention in the form of procedures or even surgical management. So, and botulinum toxin of late has evolved as one of the many of the armamentarium in physicians' hand to treat spasticity. And we realize that there are a lot of apprehensions about people. There are a lot of apprehensions in the mind of clients when we discuss botulinum or the option of botulinum toxin with them. So we thought that this presentation will act as a stimulus for people to know about botulinum toxin and to see whether their client can benefit from botulinum toxin. So first, these are the contents of today's presentation. We'll go through the pathophysiology of spasticity. We'll go through a few slides on the mechanism of action of Botox, its indication, how to assess spasticity before we give botulinum toxin, and what are the post-injection management of spasticity. To take through the slides on spasticity, Prashanti will be joining us.
Good afternoon, everyone. Thank you for giving an opportunity, with the Manipal Hospital, as well as thank you for the IAP and WWC Karnataka. Today, I'm going to tell about the spasticity and the muscle tone and variations of in that and how to assess that. So before going into an Botox induction things, first we have to assess the tone, whether the muscle is in end up with a spasticity or it is like a flaccidity. So I'm going to introduce it. What is the spasticity? So this is like a spasticity, as we know that it is a motor and a neuron and a disorder, which is like an occurs because of the inhibition of the supra spinal and a level to the lower and a levels, where the stretch and reflexes and will not be inhibited. The overactivity of the stretch and reflexes will result in the spasticity. So as if you go the definition, it is a motor neuron disorder which is characterized by increasing in the tonic stretch reflexes due to the hyperexcitability tensions resulting from a hyperexcitability of the stretch reflex, which is a component of the upper motor and a neuron. And this is like in a velocity dependent kind, as when you are in a testing the muscle, while doing the passive movements, we can tell the velocity, the speed of the movement. So we can determine the resistance, how much it is muscle is giving. So now it is like velocity dependent. And now we are considering about the Botox. Now I have divided the pathophysiology depending upon the clinical component. It is not like pathophysiology component. In the clinical and a component, we have two main contributing factors, which is a neurogenic and a component. Another one is a biomechanical component. Neurogenic and a component, this is happens because of hyper excitability of the stretch reflexes, and the biomechanical and a component is the stiffening and the shortening of the muscles and the other soft tissues. And it is an important and that the Botox itself is an effective in controlling the neurogenic component. When it comes with the biomechanical component, it is a important spasticity level. Now, when it comes to the tonal changes, we have when muscle tones are different types, which is like an spasticity, rigidity, cramps, and spasms, myotonia. Myotonias, neuromyotonias, and the contraction. And the main thing and where we get confused is whether it is in spasticity or the rigidity. These two are the different components which has to be differentiated from each other before going into a Botox injection. Because Botox injection is most helpful in the focal region of the muscles. The spasticity just comes from the corticospinal and pathway lesions, and whereas the rigidity, it is a levodopa deficiency which happens in the basal ganglion. The tetanic spasms are because of the calcium and the magnesium and ions and deficiencies. And the myotonias, these happen because of a slow muscle relaxations due to the myogenic electrical hyperexcitability. And the neuromyotonias, it may be an hereditary or it is acquired due to the peripheral lesions of the nervous system. And if it is contracture, when the muscles is going into a shorten for a long period, it will end up in the contracture, and these contractures will and leads into any deformities of a particular joint. And the paroxysmal symmetric and a generalized and a spasms is in the spinal lesions, we can see that. And we have a diagnostic and tools and for all this, where we can do the neural imaging and methods where the lesion is in the higher centers or it is from the lower centers, and this spasticity is always depends upon the site and the size and the age of the lesion. So now when it comes to the dystonias, these are the prolonged and muscle contractions which resulting in the abnormal and movements and the postures. The dystonia which commonly seen in the dystonia spasmodic or the clinical and a level, we'll see it in the most and a common in areas. The signals and from the brain, it will not reach into the neck muscles. This is like it might be in a flexion dystonia seen in the Parkinsonism, or it might be a spastic and a dystonia which seen in the stroke or in a hemiplegia, paraplegia cases, or the torsion dystonia, or segmental, or the decerebrate and rigidity which seen in the head injuries. Now it is like we have to know if we will not treat the spasticity, what is going to be and happen. If it is, why the medical management is an important for the spasticity. The spasticity, if you leave it like that, and it may end up with the rigid and a muscle tightness and the contractures deformity, and indirectly it will affect the functional and a component of the patient, and it leads the psychological and a depression of the patient. So the secondary complications arising from the spasticity is like it will impair the movement and the hygiene of the person, and the self-care, and I think they have to depend on somebody else, and the poor and self-esteem, uh, they will have a pain, and it may end up with the pressure sores. Now we have divided the limitations of the spasticity according to the ICF model. In the ICF model, it is like an impairment and the activity limitation and the participation restriction. When it comes to the impairment, the body parts, whichever the muscle is involved, it may result into a muscle spasms, and if it is involved in the trunk and the limb muscles, it may difficult enough for them to maintain the posture. As a result, they may end up with a pain. Now, when it comes to the activity, there will be an active function loss which can be used by the paratic limb, or it may be the passive and a function and a loss, like which the patient may not able to do their activities of daily living. And the participation, because of this, they may not able to be socialized, and the self and a confidence on them, it may reduce. So now it is the questionnaire time. We are going to ask whether the spasticity is due to the loss of an inhibition from the supraspinal level. Option A is yes. Option B is no.
They can respond in chat. Then you can continue. Wait for 30 seconds. Okay.
Yes. Hope you guys understand the question. And the answer for that is yes, because the spasticity occurs in a loss of an inhibition from the spinal from the cortical level. So now we have a common assessment and tools which is used for spasticity. One is a Tardieu scale, another one is a modified Ashworth scale. The most commonly the clinical physiotherapists are using the modified and Ashworth scale. So the grades of a modified Ashworth scales are 0, where there is no increasing in the muscle tone, and the grade 1 is a slight increasing in the tone with a catch and release or a minimal resistance at the end range. 1 plus is slight increasing in the tone, giving a catch followed by a minimal resistance throughout the range of the motion. And the grade 2 is more marked increasing in the tone, but you can able to move the affected in a limb. And the grade 3 is there will be a considerable increasing in the tone. It may be difficult for a therapist to do a passive movement. And it is grade 4 is the affected and a part will be fixed in either in flexion deformity or in extended deformity. So the third scale, I am just going to give a gradings. Dr. Naveen is going to discuss in detail about how to perform that and what will be the angle to be taken while giving the Botox. Just the zero grade is there is no resistance throughout the passive movement, and the grade 1 is light resistance throughout the movement, and with there is no clear catch at the precise angle. This third scale is depending upon the angles, and the grade 2 is the clear catch at the precise angle followed by a release motion. And the grade 3 is the clonus you can see when you are trying to do a stretch that it's lost for about 10 seconds. Like in a grade 4 is, it is an unfatigable clonus will be there which lost more than 10 seconds at the particular angle. The grade 5 is the joint will be immobile. The common other tools which can be assessed clinically as well as the functionally. The clinically, as I told you, it is a modified Ashworth scale, and before the modified Ashworth scale, the Ashworth scale was used in practice. Now, like the spasm severity scale and the tone assessment scale and third or modified third scale. And when it comes to the functional, this is important for a therapist, like whether they have improved. That is based on whether the patient is able to do independent in their activities of daily living. That we can be assessed by through the disability assessment scale and the Fugel-Meyer scale, where it is an upper and the lower component and the transverse activities, and Barther and index and the functional independence scale. Like we have one evidence-based article showing that there is a lot of literature is going on for validity and the reliability of the TART scale, which is commonly used. And this is like this one is this study was done in 2006 following a Botox treatment. Like why we have to go for Botox. That is like main thing is, as I told you, it is like stiffness of joint, which stiffness of muscle, which hinders the person to do their activities. In that case, then we have to reduce the muscle and tone, and they have to participate in doing their own self-care and activities. So to improve the muscle tone and facilitate the voluntary movement, and we have to maintain the muscle length across the joints, and to facilitate like care and givers for an easy work, and to facilitate the active and control of any residual movements to allow the active participations in the task. As I told, it's like mainly for to improve the ADL activities and the social participation. From here, the Dr. Naveen is going to continue.
So this slide shows us some of the treatment modalities that we commonly employ for treating spasticity. So you can see that among the generalized treatment, the most common thing are oral medications. There are so many medicines that we use for the treatment of spasticity, but these medicines come with its own problems of side effects and the fact that you need to use it for a long period of time. Then there are regional methods, like you can go for botulinum toxin injection or phenol or alcohol, neurolite or intrathecal therapies like baclofen intrathecal. And I'm coming to the focal treatment. Among the focal treatment, perhaps the most common nowadays is botulinum toxin injection. Earlier, it used to be phenol or alcohol neurolysis, where we used to inject either 6% phenol or alcohol into a nerve under the guidance of a nerve stimulator. So let me talk something about botulinum toxin. So as many of you might have known, botulinum toxin is something that is, it's a toxin that is produced by a bacteria known as Clostridium botulinum. And they generally cause a condition known as botulism. We don't have the Indian data with me right now, but on an average, botulism is a condition that is seen almost around 150 to 200 cases per annum in United States of America. And most of this botulism are caused by uh, foodborne botulism or infant botulism, where they use um, preserved food stuff like honey for the kids. And there is also 25% of cases which are caused by wound botulism. So this Clostridium botulinum produce 7 or even now 8 antigenically distinct protein, and these neurotoxins are labeled from A to G. Among all these 7, 8 proteins, only A and B are commercially available. And among this, botulinum toxin A is considered as the most powerful neurotoxin that is available in the world. And the common brand name that we heard about, like Botox or Dysport or Xeomin, these are all using type A toxin. So the brand Botox is available as 50 units as well as 100 units and 200 units. They are these vials are vacuum sealed to guarantee sterility, and each vial is for a single use. We have to reconstitute using normal saline before injecting this Botox. So coming to mechanism action, here you can see uh, botulinum toxin prevent the release of acetylcholine from the presynaptic nerve terminal. So you can see that in the neuromuscular junction, there are synapses. So for the normal transmission of nerve impulses, you need to have this acetylcholine vesicles, which releases the acetylcholine into the presynaptic spaces. So what happens is that the Botox, when we inject, they reach the this neuromuscular junction, and they attach to a receptor protein by which they prevent the uh, uh, release of this acetylcholine into the presynaptic spaces. So this will result in reduction in muscle contraction and a dose-dependent reversible reduction in muscle power. And it has been found that an active neuromuscular junction take up botulinum toxin A more avidly than a neuromuscular junction at rest. For example, when we are injecting for biceps, we try to activate the biceps passively or even semi-actively. And during that process, if you inject, that muscle is more likely to take up Botox or botulinum toxin A more avidly than a muscle which is in rest. So the clinical effects after the Botox are actually a temporary effect. It lasts for say 3 to 4 months. And after 3 to 4 months, what happens? The toxin will degrade and become inactive within the nerve terminal. Along with that, our body is capable of having this concept known as synaptogenesis, where new synapses are formed, which will be able to overcome the blocked synapses. And along with that, there are some of us or some people in general can produce neutralizing antibodies. And these neutralizing antibodies can also block the Botox, which is actually a protein. Just like nowadays we have heard about antibodies against our coronaviruses. So the same way, these antibodies can also finally neutralizes the active Botox in the body, and hence the effects of Botox are reversible and are often temporary, even though we can make a long-lasting effect of the Botox if we combine that with proper rehabilitation interventions. So botulinum neurotoxin A is injected intramuscularly into the selected muscles. Although it can diffuse through the muscle facial barriers, its effect is concentrated in the injected muscles so that it is possible to generate a highly focal effect or weakness. The injection do not have to be placed precisely in the motor end-plate zone, as Botox can diffuse to some extent within the muscles. But of course, the best effect of Botox is obtained when we are able to inject as near to the motor end plane. And once it is injected, it is taken up by the NMJ within 12 hours. And clinical effect usually occurs over gradually over a period of 4 to 7 days. And the clinically detectable effect, as I told earlier, can be seen for 3 to 4 months in most of the situation. And the clinical benefit can persist for many months, particularly when it's accompanied by an appropriate physical management program. What are the adverse effects when we use Botox? This is one of the most common question that clients will ask or patients will ask us, or the patient party will ask us when we suggest Botox to them. So the most common side effect, I would say, is the local muscle weakness from the toxin spread to a nearby muscle. For example, we are injecting to a flexed elbow. Our plan is to inject the elbow flexus, and when we inject to the brachioradialis or biceps or say brachialis, there is a possibility that some amount of toxin spread happen to the triceps. So we get an unwanted weakness in the triceps. So this may cause a temporary function loss. And very rarely, you can get more generalized muscle weakness. This happens especially when we inject very high doses given in multiple muscles. So for example, if you are injecting a tetraplegic patient where there is spasticity involving in his upper limbs as well as lower limbs. So if you are injecting the maximum dose that is possible, okay, very rarely we might be able to see some generalized muscle weakness. But this is a theoretical possibility. It's very, very unlikely to see such generalized muscle weakness. Similarly, dysphagia and other bulbar symptoms can also occur when we give high doses in and around the neck. For example, cervical dystonia. So when we inject in the case of cervical dystonia to the neck muscles, yes, there is a possibility of similar side effects in the form of dysphagia, dysphonia, or even dyspnea in such patients. Autonomic dysfunction is another theoretical possibility, and it's, if at all it occurs, it almost subclinical, especially in patients who have Parkinson's or diabetic patients who are long-standing diabetes who already have some amount of autonomic dysfunction. Flu symptoms have been reported by a few patients, but usually seen in the first week and is often very transient. And other rarely reported side effects includes rashes, altered taste, and brachial neuritis. Again, these are very, very rare. I'm just describing them for the theoretical possibilities. Now, coming to the indications. So broadly, I have divided the indications for Botox into 3 groups. One is early interventions. The second is therapeutic interventions. And third is patient care interventions. So this early intervention is something that is still being studied upon, still being researched upon, where botulinum neurotoxin have been shown to provide a sustained reduction in post-stroke upper limb spasticity when it is combined with the rehabilitation in patient as early as 2 weeks after the stroke. It's very unlikely that many patients who are in the acute stage in the hospital, when we introduce Botox to them, they are going to agree for it. But still, we have few cases where we have injected as early as 3 weeks or even 4 weeks. And a couple of studies have looked into this aspect, and they have found that the functional use of the arm and hand was not adversely affected by this early use of botulinum toxin. So if used appropriately in the early phases of rehabilitation, it may prevent the soft tissue shortening arising from the combined effect of spasticity and limb immobility. Now, coming to the other intervention, so you can, again, as I told earlier, you can divide that into therapeutic interventions and patient care interventions. Now, therapeutic interventions are those interventions where we can expect some foreseeable change in the rehab status. For example, a cerebral palsy kid having a severe hand dystonia. There is a possibility we get good relief of dystonia with this Botox to its when we inject Botox to the kid's hand. Or similarly, when a adult stroke who is having severe spastic weakness, so if we can inject to the calf muscles, so gastrosoleus and tibialis posterior, there is a possibility that gentleman or woman can walk without the splint by having a proper gait after injecting with Botox. Similarly, there are many patients who have severe toe clawing because of spastic clawing, and this toe clawing can also respond to botulinum toxin, where by making them possible to walk barefoot. For example, the person have to walk to the bathroom in the night, and such a scenario may not happen unless he uses a splint or a shoe. So in such scenarios, there is a possibility we are able to change the rehab status. Now, coming to the patient care intervention, these are conditions where the rehab status or the ADL is not changed. The classical example would be a pain relief, for example, a spastic shoulder following a stroke or following a traumatic brain injury. The severe painful shoulder because of severe synergy pattern in the early phase can produce severe pain. So this might affect its overall ADL, overall symptoms. So here we might be able to bring about pain relief just by giving injection Botox to those spastic synergetic muscles. Similarly, ease in patient positioning. For example, a bedridden tetraplegic guy or a paraplegic guy who is having severe um, spasticity in hamstring, which makes us very difficult to position him on the wheelchair. So a reduction in the tone of hamstrings by giving botulinum toxin injection might help him or help us in at least making him wheelchair bound. Or maybe personal hygiene, for example, severe adductor spasticity, where the cleaning of the perineal region or the perineal hygiene can be a big issue because of the severe adductor tightness. Again, Botox injection to those adductor muscles can bring about huge change. Now, there was a time when Botox was given blindly by palpating the muscles that we are targeting, uh, having known the exact surface anatomy. We were able to inject, even now also, most of the superficial muscles, like say biceps, for example, or hamstrings, or even the rectus femori, can be approached in a blind manner. But of late, a lot of studies are saying localization techniques will help us to make it more precise. That will also help us to reduce the amount of medicine or the dose we are using for a particular muscles. So these are the localization techniques nowadays which are being used. One is EMG, especially these are mainly used by the neurologists who are well versed with EMG. So EMG can be used to confirm the placement within the muscles, and the presence of the muscles can be obtained by looking at hearing the EMG sounds. Similarly, we can also use a nerve or a muscle stimulator, which can be used to confirm the placement by producing the twitch reflex in the target muscles. And of late, perhaps the most important or the most popular localization technique nowadays has been ultrasound imaging, ultrasound scan, where you can visualize the muscle. And perhaps the most important thing is that it helps us to avoid structures like a nerve or a blood vessel when we inject to a particular muscle. For example, if you have to inject to tibialis posterior, you have the neurovascular bundle going close to the tibialis posterior muscles, where if you can use an ultrasound, we can avoid the neurovascular bundle so that we can target the injection to the muscles directly. Now, how do you select patients? Part of it had been dealt by Madam Prashanti, but I will like to touch a few points in how to select the muscle, how to identify muscles, what are the points that we look when we uh, think about giving botulinum toxin injection. So most important thing being identifying the spasticity. Prashanti had described detail regarding the modified Ashworth scale. Um, Another one is to how to differentiate between a spasticity from a contraction. To some extent, this can be done by modified Tardieu scale, but often we might need other high-end techniques like EMG or even examination or anesthesia to completely rule out that part. And some scale that I would like to talk about is goal attainment scale. I will talk about that a little later. So I would like to talk about modified Tardieu scale, and here we look upon the muscles respond to stretch when the stretch is applied at a given velocities. There are three velocities we look at: V1, V2, and V3. V1, when the range of motion is applied as slow as possible, so as to minimize the stretch reflex. V2 is the speed at which the speed of the limb segment will fall under gravity. So if you lift your biceps and allow it to follow, if you lift your elbow to allow it to follow, that is the speed at which we want to use V2. And V3 is when it is done as far, the range of motion is done as fast as possible. We also measure two angles, R1 and R2. So the R1 is the angle of the range of motion, where the angle of the catch is followed by fast velocity stretch. For example, when we do the range of motion in V2 or V3, you can feel a catch at one particular angle. That angle constitutes R1. And R2 is the passive range that is obtained when we do it with a slow velocity stretch or V1 velocity stretch. So here you can see in the diagram there is R1 and R2 when we are checking the range of motion for the ankle, and similarly when we are checking for the hamstrings or the knee, there is R1 and R2. So more the difference between R1 and R2, better will be the muscle's response to Botox. That is one point that I want to highlight here. If the R1 and R2 are too close to each other, there isn't much dynamic component of spasticity there, where Botox may not be that beneficial. So larger the difference, the large dynamic component, and there is a large window of opportunity for changing this R1. And smaller the difference, there is a static component which is more, where Botox may not be that beneficial. So the Botox is useful in patients with an early catch and almost full passive range of motion at R2. Now, when we do statistical analysis for patients with spasticity, where it is for outcome of Botox injection or outcome of antispasticity medications or outcome of any physical therapy intervention or occupational therapy intervention, for spasticity, because most of the spasticity is we use modified Ashworth scale or Tardieu scale, the change is very minuscule and may not be statistically significant, and hence people have come up with this particular scale called goal attainment scale, where is a method of scoring the extent to which patients' individual goals are achieved in the course of intervention. In effect, each patient has their own outcome measure, but this is scored in a standardized way so as to allow statistical analysis. So I will also touch upon a few common patterns of spasticity and the muscles injected. So in the shoulder, as you all know, we might see very commonly that is the shoulder is adducted with internal rotated, the elbow that's being flexed, and the forearm being pronated with flexion at wrist and flexed fingers. And in some cases, there is clenched fist, or some cases there is thumb in palm features. So in the shoulder, adduction and internal rotation is the most common pattern that we will see. And the muscles where usually we target are pectoralis and latissimus dorsi and teres major. Similarly, in elbow flexion, brachioradialis is the most common muscle we target, and sometime with biceps brachii. The reason why biceps is not targeted many times is because biceps is already a powerful supinator. So in a pronated arm, there isn't much effect by injecting into the biceps. Very rarely we inject brachialis. And in uh, pronated forearm, pronated teres, and pronated quads are the two muscles that we inject, and most often it is the pronated teres rather than the pronated quads. In a flexed wrist, of course, flexor carpi radialis and the flexor carpi ulnaris are the two muscles we target. In thumb in palm, the flexor pollicis longus and adductor pollicis are the muscles that are targeted. And in clenched fist, the long flexors of the fingers, flexor digitorum superficialis and the flexor digitorum profundus are the muscles that are done. And in coming to the lower limb, in flexed hip, iliopsoas and the rectus femoris of the quads are the three muscles which are targeted. In the adducted thigh, the adductor group of muscles, which include the adductor magnus, the adductor longus, and adductor brevis, are the muscles which are targeted. And in stiff knee pattern, the rectus femoris as well as the vasti group are targeted. And in flexed knee, it's the medial hamstrings rather than the lateral hamstrings, that is biceps femoris. The medial hamstrings, especially semitendinosus and semimembranosus, are the two muscles which are targeted. And in equinovarus foot, it's the gastrosoleus and the tibialis posterior muscles which are targeted. And this is something that we might have seen, the striatal toe or the hitchhiker's toe, where the extensor hallucis is longer of the big toe and the flexors, the long flexors of the other toes are targeted. Now, once we inject, these are some of the protocol that we follow. Patients are started on therapy from the second day itself, starting with stretching. Some patients, especially for spastic equinus or a spastic wrist with clenched fist, we make sure that the patient already has a splint which are to be used immediately after the injection. We also combine electrical stimulation. What the protocol that we follow is that we do electrical stimulation to the injected muscles for the first 3 days to 5 days, and followed by functional electrical stimulation to the antagonist muscles, so as to bring about the functional changes. We also have, rather than sticking to one of this technique, you have a combination of this one along with the conventional therapies in the form of constraint-induced movement therapies. We do continue. Prashanthi will now continue with the therapeutical aspect of post-injection procedures.
Yeah, hello. Till now we had seen what is the Botox and what is the indications of the Botox, and like which are all the muscles and they are going to target to improve the range or it's a functional activity. Like after an injecting, now what is the role of a physiotherapist? What is the role of a physiotherapist? Now I'm going to discuss it. Now it is in a post Botox and a therapy. It's a commonly the everyone will use is a normal and a passive range of motion and stretching exercises, or if it, they will give an a splints to maintain that in a sustain and a stretch for a long time and not to go the muscle into a contractures, and there will be a weakness of a muscles once if they induce a botulism. So once if it is the muscles are in a weak, and sometimes it can happen because of very mild and spasticity, they may participate in the functional and activities, and after an injecting and they may lag in doing that functional activities. So we have to concentrate on that the muscles which are all weak, and we have to strengthen it. The common thing and now we do is a neuromuscular electrical stimulation after the Botox injection that is given by both for an agonistic muscles as well as an antagonistic muscles. And we have to restore the biomechanics like a muscle length and muscle tension and muscle relaxation properties of a muscle, and this can be done by putting in a serial and a casting, or it is in a splints, or by doing a stretch, because while doing an exercises we can give a stretch for some time. That stretching is may not affect to maintain the muscle and length throughout the day. So for that we may use for splints. And the next thing is like we have now recently come up with a biodex, which is called a body weight supported and a treadmill. It's like useful for the patient and for the lower and a limb to improve the gait pattern, especially there in a step length and like there and single stance timing and the speed of the gait. You can see the improvement. And the functional electrical and stimulation, and next one is a strengthening of the weakness and a muscle. And now it is like aquatic and therapy, where it is like it gives some sort of a resistance to improve the muscle and a power, and they will feel because of the buoyancy effect, and it may not give so much of a strain to the patient they are doing some exercises. So, and one more thing is like a constant induced movement and a therapy, where it is like an use of the affected and a limb by tying them into the normal limb. We will not allow them to use a normal limb. And the biofeedback, this is gives a very positive and effect to the patients, and they will come to know how much the improvement they have done, and like what are all the mistakes they are doing while doing the exercises or for to complete a task. So it helps them to correct. And the next one is a motomed, which it acts for both the upper limb as well as a lower limb to strengthen the muscles. And like as usual, you have any physical modalities like an ultrasound or thermotherapy or any vibrations to release the pain. Now we'll just go to the some of the review of an literature, what they have done on these treatments. So here it is like when research has explained that the electrical and stimulation to the exercise, electrical stimulation exercise for the injected muscles. They have done electrical and stimulations for almost 72 hours after the Botox, first Botox and injection, and they resumed exercises and which has been done 3 times a week for 6 months. And they found that there is a combined effect of an electrical and stimulation as well as the conventional and therapy to improve their functional activity. And the other, which has been published in 2012 in Rafael Fortuna. The next review is the effect of combined use of an botulinum toxin type A and the functional electrical and stimulation in the treatment of an spastic and a drop foot after the stroke. It's like after the stroke, the commonly you can see the dorsiflexor weakness and where they can not able to do the heel strike while their gait pattern. So in this kind of patients, and they have used the functional electrical stimulations for their gastrocnemius and the tibialis posterior and a muscle on a daily basis for about 16 weeks to help in a better gait pattern. And this was published in Catherine et al. At 2004. Now it is like effect of EMG biofeedback and induce the efficient and muscle and re-education for improving the physiological and movement of the spastic parietic and hand. It's initially people will adapt to the abnormal and a pattern we call as a synergic and a pattern in the strokes. Like we have to break that in a synergic and a pattern after certain and a period. Otherwise, it may be developed into a postural and a imbalance. So they have done a study on this, the parietic muscles to facilitate the movements by using the EMG. and the FES. So they found it is like it will helpful for improving the activities of daily living. It was published in 2016, Mayo Tushia et al. And the effect of rehabilitation and botulinum toxic injection on the gait in a stroke, in a chronic and a stroke patients. In a chronic stroke patients, as statistically it will not show a very significant, but functionally it helps in a better gait pattern, which was published in 2015 Nicholas. And now it is like the effect of dual therapies, like two modalities and combining we are giving with the Botox injection, and the another group they will give only the Botox injection. It here they have used and facilitated EMG and a technique along with an FES for the re-education of the muscle, and it's they also concluded in that they have proven that it is like useful in improving the activities of daily living. It's like published in 2016, Mayo Tushia et al. The effect of rehabilitation and the botulinum toxic injection on the gait in the chronic stroke, which was the same thing. Like rehabilitation, it's like along with the normal range of motion exercises and strengthening exercises, then some therapies they have added up, which is like an ergometer cycling called motomed, and there is a serial casting or splinting, or if it is in a very mild contractures or very mild muscle imbalance, they have added with the taping techniques to know the effect of the combined therapy, and they find that combined therapy is slightly more effective than only Botox treatment alone, and it was published in 2014 by Nika Kinner et al. So now it's like an intensive therapy in adults for reducing spasticity after a stroke. They have done a randomized and a control and a trial. It's like where the experimental group they have received 8 week intensive rehabilitation and a program, and there is in a group 1 which received only a single dose of Botox only without any intensive rehabilitation program. But when you see the people who are taking alone the Botox, the group 2 who are received the 8 weeks intensive therapy rehabilitation along with the Botox, they are benefited much better than the group 1. So now it is like how it affects functional electrical stimulation in the treatment of spasticity to prevent a foot drop. It's like this is like the functional electrical stimulation it is an effective when you are giving on a daily basis for about 16 weeks. It helps in a better gait, and it will assist them in a walking. Now I'll just move into whether it is like an electrical stimulation will help before injecting and after injecting the botulinum toxic injections. The electrical stimulation, it will enhances the effect of the Botox when they will given if it's applied after injections and rather than before. In this it is published in Rehab General and Medicine 2011, and it is one more in a review to prevent a foot drop in a spastic and a foot drop with the combination of botulinum toxin and the electrical stimulations. And there will be a direct effect of electrical stimulations which to improve the tone on the tone reduction and the toxin uptake given by the Botox, and which it enhances the weakened muscle tone, and it improves the receptors to accept the botulinum toxin for reducing the spasticity, and it protects from any degeneration. Now it is like we have some other approaches like task oriented therapy, which mainly emphasizing on their upper limb to improve the functional activities. And this is also task oriented therapy is helpful along with the Botox injections. But it's remember that it's only the Botox is not going to be an help, and only the physiotherapy is not going to help. by seeing all these articles, you can tell that it is in a combined effect of both injection as well as a physical therapy. These are all some reviews and which we can do it. This is all the dual therapy and which is like in a chronic stroke patients and all. Now we have some videos in where we can show the improvement in the patients for an upper limb and activity as well as for an lower and limb to improve the gait and to improve the gait in the lower limb and to improve the hand function in the upper limb. This is like once if you are in a training with a biodex and before giving a Botox and a physical therapy, you can see a graph which is projecting like the step length and the speed of the patient. Now after 6 weeks of therapy, now there is an increasing in the step speed of the gait as well as in a step length, and there in a balance on the single leg support has been improved. Now we are going to play videos on a gait.
Don't speak.
This here you can see while walking there is a hip hike and a hip flexion is there, where the knee is going into a little
Sorry
torsion
to
and
interrupt you.
flexion. And,
We are not able to see the video.
you're not able to see it. Yes, a minute.
Don't speak.
Just a minute.
Don't speak.
It's a technical problem. We are going to rectify it. Yeah, is it coming?
No, it's not.
Speak.
Now?
No, it's not coming.
It's not coming. Just wait a minute.
Yes, yet it came, and then it.
Okay. Okay, we are going to replay it.
Don't speak.
Are you able to see this?
No, 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 no. Now, no.
It's now it's coming.
No. It came in between and just went
Don't
off.
speak.
Okay.
Don't speak.
Sorry for the inconvenience. We are trying to fix it out.
Don't speak.
Yeah, now it's coming. Are you able to hear me?
Ma'am, I'm able to hear you.
No, no, it's not.
Yeah. Whether it's
Yes, I'm.
okay?
Pooja, can we go to the next
Not able.
question answer session?
Don't speak.
Can
Yeah.
we go to the question answer session then?
Yeah, sure.
Okay.
Yeah, doctor is also joined here. You
Yes.
can start the questionnaire session.
I really want to say sorry that I could not introduce Dr. Prashanti. She's works with rehab in Manipal Hospital. I actually didn't think that you both will be talking together. I thought Naveen sir will talk and after that you will be talking. It was really knowledgeable session, and I'm sure all of us would have gained some knowledge about Botox, that how Botox can help us in our therapy. There are few questions which has come up. So the first question.
We are extremely sorry that our technological or technical ability in laptop and system use are not up to the standard.
That's absolutely okay. You should be good with patients, not with laptop. So yeah, the first question which has come up is it necessary to give second dose of Botox injection? If it is so, when is the ideal time after first dose? That's for Dr. Naveen.
Okay, so it depends upon whether we have got adequate uh, the so-called targeted results after giving the first injections. For example, let's say we have a patient who had a flexed elbow posture and we have injected to the brachioradialis and biceps, and after a month of say 2 months or within a month itself we should get the desired effect, and at the end of 1 month if we are completely sure that our the technique of injection was correct, our dosing was correct, we have verified that with ultrasound that we have injected in the right place and we haven't got the desired effect, yes, we can give a sort of booster injection. Nowadays, we do give that injection even within the first 1 month. Earlier, see, a couple of years back, we never used to inject in the first 3 months. That was the concept that people used to follow because there was a question of antibody formation in the first 3 months. If there was a concept that if you inject repeatedly, there is high possibility of antibody formations, and which might negatively impact the effect of the Botox. So earlier we never used to inject in the first, once we have given an injection, we never used to inject in the first 3 months or 4 months. But nowadays we do give sort of Botox booster dose even within the first 3 weeks or even 4 weeks. If we feel that this might, we have some action, okay, we need more action, more benefit, okay, we can give a booster dose. We have injected within 1 month itself.
Okay. The second question goes again for Dr. Naveen. Is it applicable on grade 4 spasticity?
It's a very controversial question, I would say. Yes, it is applicable, but there is a possibility once we have reached a grade 4 spasticity, there is some amount of mechanical component to it. There is a possibility that we are looking at some amount of contracture here. There is a possibility that the muscle have shortened here. So there is very high chances of failure. Rather than failure, we would say we may not get the desired effect at a stage 4 grade 4 spasticity. The best thing that I would suggest in such scenario would be to rule out. Of course, we can to some extent clinically rule out a contracture or rule out a difference between a contracture or a grade 4 spasticity. What we can do is do an EMG to see whether it is actually a spasticity or contracture, or we can even do an examination under anesthesia to see whether there is an element of contracture. But grade 4, in my opinion, I will think twice. I would prefer to inject in a grade 1, 2, or 3.
Okay, okay. And what are the contraindication for Botox injections?
The main contraindication that I face is one, if a patient who is on a aminoglycoside antibiotic, for example, a person who had a urinary tract infection or a urosepsis or a severe UTI for whom he's on aminoglycoside antibiotic like an gentamicin, amikacin group. Aminoglycosides along with botulinum, because aminoglycosides also have some effect on the neuromuscular junction. So that is one sort of a relative contraindication where you have to wait for some time before you inject. Second major contraindication would be a case of myasthenia gravis or any conditions like Lambert-Eaton syndrome or myasthenia gravis, which actually has its effect on the neuromuscular junction. So such patients, we don't have many studies, and I would say theoretically it is not good to inject for this kind of patients. Then a patient who have severe myopathy for a Duchenne muscular dystrophy producing contractures or shortening, I don't think Botox will have any effect.
Okay.
Neuropathy is sort of a relative contraindication. For example, a patient who has spastic um, foot drop, along with that, he also has a severe diabetic neuropathy. It is again sort of a relative contraindication, I would say.
Okay. Is there any age criteria?
Absolutely no. I would say I would inject even a 2-year-old kid or a 100-year-old gentleman if he's fit for having Botox. Yes, I won't say any age criteria in that way.
Okay. This question is for you, Dr. Prashanti. When to start therapy after Botox injection?
Usually we used to start after the second day of the Botox injection.
Okay.
The reason why we select a second day is because even though literature say we can inject, we can start therapy in the first day itself, but there are many elderly people who might be on a blood thinners like a Cosprin or a clopidogrel. So we will say one day it's better we wait. Next day we'll start the therapy.
Okay. What is the criteria for FES?
The criteria first thing is the patient is able to understand the procedure and they have to follow the commands. When it comes to the muscle grading of it is in a 2+2 3, we can include in them, and where they have typical strength, good strength in the hip flexors and the extensors.
Okay. How does Botox injection and physiotherapy complement each other in cerebral palsy?
In cerebral palsy, you can see the spasticity is more which is of higher centers. This when it continues for a long time, the muscles gets shorten and stiffen. There is a high probability of getting a deformitis. So before and ending up into that in a stage, if you inject a Botox and along with the physiotherapy and effect, you can able to maintain the muscle properties.
Okay.
Yeah, that will be the main thing, so that we can, because we are looking at a chronic kid, a kid who will grow into an adult with the deformities or disabilities. So we might be able to prevent some sort of muscle shortening if we identify the tightness and we realize that this kid is going for a shortening in the future. I would say along with therapy, Botox will definitely complement. We might be able to prevent some of those difficulties, but there is every possibility that kid might be requiring injection perhaps every year.
Okay. Is Botox can cause release of lactic acid?
Theoretically, yes. Theoretically, yes. But the difference is that, for example, lactic acid is actually a product of an ischemia. So if you have a very severe spasticity, you're looking at a grade 3 or grade 4 spasticity, and that spastic joint can produce high amount of toxic metabolite in the form of a lactic acid, and this lactic acid can be one of the reasons for pain in a contracted or a spastic joint. So Botox, in that way, by relieving that spasticity, Botox might be relieving that ischemia and causing reduction in the pain. Of course, the process of injection might cause a little bit of lactic acid release, but that will be negligible.
I think it's the last question. Any complications by using Botox? Any complications by using Botox?
So again, in the presentation I have mentioned, see, there are a lot of theoretical possibilities of complications. But in my 15 years, I can say that none of them were major. None of them were life-threatening. None of them were something that demanded an immediate attention. Of course, maybe because of the fact that I haven't injected for cervical dystonia, because here in Manipal Hospital, cervical dystonias are injected by our neurology team. So they might have encountered such issues like a dysphagia or dysphonia, things like that. But for spastic lower limbs, spastic upper limbs, especially the distal forearms and all. No major side effects is something that I would say.
Okay, this one is the last one. What is your opinion about baclofen pump?
Baclofen pump is, let me put it this way. So if you have a highly spastic tetraplegic, and we have identified that all his muscles in the upper limb and lower limb, all major muscle group in the upper limb and lower limbs are spastic. And if you calculate the dose of Botox in such an individual, the required dose will be very high, which will be above what is suggested by the FDA. So we cannot inject more than 500 or 600 units. So if you are looking at a tetraplegic or a paraplegic with severe spasticity, when we calculate the dose requirement can be above 500, 600, 700, or 800, where the possibilities of side effects are there. And there is a possibility in such cases, okay, we can inject Botox and see whether it was helping him in relieving spasticity. Yes, we found that it has some effect, but we didn't get the desired effect. So in such a scenario, for a generalized spasticity, we discussed that part. Botox is especially useful for a focal spasticity, like a spastic upper limb, a spastic shoulder, a spastic clenched fist, or spastic ickiness. But when we are faced with a generalized spasticity, we have to look for a procedures like intrathecal baclofen, or even procedures like other spinal procedures like dorsal rhizotomy, or maybe even cerebral procedures which are done by the neurosurgeons.
Okay. Thank you, Dr. Naveen and Dr. Prashant. Thank you so much. It was indeed knowledgeable, and with so many questions coming, we understood that people were listening as well. So I, on behalf of entire team of IAPWC, want to thank our guest, Dr. Iftikhar Ali sir. Sir, thank you so much for taking out time and being there for this webinar. For our speakers, for sharing the knowledge and work with us and gracing our webinar, Dr. Naveen and Dr. Prashanti, I'm really thankful to both of you. It's my privilege to have been asked to propose a vote of thanks on this occasion. A big thank you to Dr. Dheeraj Adiga, sir, Dr. Manish Rai, sir, Director Manipal, Dr. Kshitija, DGM Operation Entire State, IAP and IAPWC Karnataka, Dr. Dhanalakshmi from Manipal. I'm really thankful to you because you helped us organize this talk. We would like to acknowledge our gratitude towards all the participants, because if these participants were not there, this webinar was absolutely not possible. So I'm really, really thankful to all the participants. Last but definitely not the least, I'm really thankful to Dr. Ruchi Varshne for, keeping the spirit of IAPWC, that we can together bring such seminar for you. I am really thankful to my whole team who thought of, bringing such knowledge even at COVID-19 times. Tomorrow also we will have a webinar at the same time on surgical management of tendon injuries and hand and rehabilitation by Dr. Shrikant V and Dr. Manumi and Dr. Swarna. So all of you, I would request you to register yourself for the same, for the meet. Dr. Sumita will be, I think, posting in all the groups. So please register and please come for tomorrow webinar as well. Thanking you all. Thank you so much. I think